Hello, I'm Dr. Maury Markman from City of Hope. And in this concluding session of this all too brief discussion of the evolution of surgery in the management of cancer, I want to highlight several final points, including very specifically what I consider to be one of the most significant changes in cancer management over the last several decades. And this is the increasing role of surgical management of known metastatic cancer. When I began my oncology career many years ago, if a surgeon were to say to a group of colleagues, oh, this patient has known metastatic disease to the lung or to the abdomen, and said, well, I'm going to try to take that metastatic disease out, you would say, number one, what are you thinking? And number two, maybe we ought to have your performance reviewed by the Hospital Quality Control Committee. What was the role for this? Now, there was always a role, of course, for surgery in the palliative treatment. Patient who had a bleeding lesion that couldn't be controlled with radiation, for example. You could potentially take that out, all for palliation, to allow the patient to be more comfortable, maybe live a little longer. But it was as limited as possible and it was truly for palliation. Or, a patient who had a bowel obstruction, you wanted to surgically bypass that. That was always an acceptable modality. It was only for palliation. The goal wasn't to remove the cancer per se, because surgery was not seen as having a role in that. Over the years, that concept began to slowly change, with the idea that certain tumors, if they were metastatic, they may be metastatic to localized sites and not spread widely. For example, colon cancer to the liver that might be noted for the first time a year or 2 years later, no other disease on imaging, to go in and take out that mass or several masses, because that may be the only place where that cancer, for biological reasons that are not clearly understood, had spread to. The idea of a osteogenic sarcoma, that patients seem to be doing fine, but a year, 2 years later, an isolated lesion appeared in the lung, to take out that nodule in the lung, again, because the biology of the disease appeared to me that cancer could have spread widely, but it hadn't. It had spread to a localized area to take that out. So the idea of using surgery later began to become a part of the standard armamentarium. And today, with the effectiveness of systemic therapy, effectiveness of radiation, the idea that you remove large tumor masses in concert with a multimodality approach that used effective systemic therapy has become widely the standard of care. Of course, my own area of experience, this has been the management concept for ovarian cancer for decades. Surely, a surgeon going in and removing large bulk disease in ovarian cancer was not the reason these patients lived much longer, because you can certainly never remove all the cancer, but it was the association with removing this large disease and effective chemotherapy, alkylating agent based and then platinum based, which improved survival. And that concept has increasingly become relevant in many tumor types and has become the standard of care, improving effectiveness. And this is an incredibly important development. I'd like to note in conclusion two relevant critical differences to highlight between, you might say, advances in surgery versus, for example, novel anti-cancer drugs. First, drugs are very critically and carefully controlled by the FDA. And when they're approved, the drugs and dosages, schedules have been laid out both in terms of the publications as well as in the approvals. Insurance companies also will approve use of certain drugs in certain settings, not always in a positive way. Point is, there is a control quality built into this, and it's relatively easy to monitor. In contrast, when one talks about innovative surgical approaches, for example, a surgeon or a group of surgeons describe a novel approach to resection or monitoring patients. In the literature, that can easily be employed, or relatively easily employed, by individual surgeons and institutions with potentially a limited amount of oversight and quality control. I'm not saying that happens regularly. I'm saying there is a difference in the control mechanism and oversight for drugs, specifically in terms of what is acceptable standard of care versus the question of surgery and surgical control. And second, novel technology is surely approved before it's used in the surgical setting. But again, control of who uses the technology when it's introduced into the community, the required training, the required experience is not necessarily under rigorous review, and maybe widespread use before the necessary studies are done to show the effectiveness. Unfortunately, the result of this can be outcomes that may not be favorable. And I use an example, the experience with minimally invasive surgery for early stage cervical cancer, where this approach was discovered to be inferior as regards survival compared to the standard, much bigger, but standard abdominal radical hysterectomy. And this technique, the minimally invasive approach, was long used before the data demonstrating the inferior outcomes was available. And as a final acknowledgement in the completion of this three-part series, I want to note that the relevant developments in surgical management of cancer, which are so important, they simply not get the same attention within the media or academic spheres as exciting, novel, precision medicine-based anti-neoplastic drugs. However, their role in optimizing clinical outcomes for our patients should absolutely be acknowledged and never understated. And I thank you for your attention.